the golden claim, or making sure you've got your first pass rate very high, meaning you don't have to worry about it. What I tell practice owners is every time you have to touch a claim, you're eroding at the dollar that you're owed, because it's your time, it's somebody else's time, it's technology to deal with it. So you don't want to have to worry about it. If it goes out and comes back frictionless, that's exactly what you want.
Kick it.
Hi, it's Kylie, and in today's Strata Stories, we're doing something new. Our COO, Casey Peters, joins me to talk about the hidden billing mistakes that cost clinics 15 to 20% of their revenue, how to design the ideal billing workflow, and why the golden claim is the ultimate RCM goal. These insights are tactical, clear, and are things that every owner needs to hear. Let's get started. All right, welcome back to Strata Stories. We're trying up something different today, kind of more of a back and forth educational, talking to Casey Peters, our COO here at Strata PT. How are you doing today, Casey?
I'm doing great. How are you, Kylie?
Doing awesome. I'm going to just throw out a couple questions and then you just respond back, and hopefully we get some owners or clinicians get their answers for some better RCM practices.
Sounds good.
Perfect. So my first question is, what are some common billing or RCM mistakes that you're seeing in PT, OT, or speech practices?
I'd really say two things, Kylie. I would say one is it has to do with yield. So a lot of our clients that we see, or the folks we talk to in the industry, they don't understand what's in their contracts with their insurance companies. And so one of the biggest blind spots we see is, are you truly getting paid what you should, like what is expected? Meaning that yield is what you want to maximize there. If you're owed $1, you want to make sure you're getting $1. And so lots of times those blind spots are, payers are updating their systems with their own AI and different intelligence, and it might not understand an OT claim, speech claim, the way that we do, right? And so, or the way that maybe a human does. And so, what we often see is that those systems could pay you right two claims. On the third, maybe that every third claim, they're taking 15% off for some reason. And so, those blind spots are hard to see because they're just seeing cash at the bank, but they're not taking the time to say, hey, I was owed $3, but only got two. What happened? And so lots of times they lack the technology, they lack the sophistication to understand that and see that in real time. Often when you find it, it's months, years later. Now you've got a lot more administrative work and justification to do with the payer. Say, hey, you actually underpaid me, and I need this refund. So that work is, that blind spot is pretty big for everybody. So I just say, hey, look, understand the contracts, understand what you signed, and make sure that you're monitoring to make sure every dollar comes in is whole. And I'd also say, one of the bigger things we're seeing too is make sure that as you bill out those units, make sure you're staying where you think you should be, where you're expected to be in terms of billed units. Track that over time with your AR to make sure that they kind of stay aligned and correlated together. Otherwise, you may be leaving money on the table as well.
Perfect. Kind of a follow-up question to that. Do you have any kind of like numbers or data? Like, let's say you're making a few of these mistakes. Let's say that compounds over a year. Let's say you're a mid-sized practice. Like, how much money are you leaving on the table?
You could be, example I gave, you could be leaving 15, 20% on the table, maybe more, maybe less. Really has to do with, again, understanding what are you owed. So making sure that you understand those contracts, making sure you're sensing for, hey, you build 100 claims, so simple math, 100 claims. If I'm owed $100, you can do the math there. Well, if you're over or under that, you should definitely start asking questions. Especially from Medicare is obviously one, very easy. Their fee schedule changes, but not very often. And, they're much more consistent in terms of reimbursement cycles, reimbursement dollar wise. And so just to make sure that you're sensing for some of those changes and correcting as needed, or calling your payer and having a conversation with them to see what's going on.
Another question is, if you could design the ideal billing workflow within a clinic, what would the key checkpoints be from like scheduling to claim to submission to collections?
Well, you got to think about data as a snowball. So it starts with the first name. So if Kylie presents to the clinic, it starts there. If I get Kylie's name wrong, there's a good chance it's going to get denied because the payer doesn't know which Kylie that is, who that is. So I'd always say start at the very beginning with your data collection, making sure you're getting solid insurance information from an insurance card, making sure it's being keyed in correctly. If you've got a benefit verification or policy validation check, which we do, built into our system, make sure you're scrubbing that with some sort of technology because every data field counts when you got to submit that claim to the payer, making sure you're scrubbing. So front end is super important. Get the data right, make sure the benefits are there, make sure the insurance is correct, check all those boxes. Obviously, you've got your clinical encounter. Make sure that your clinicians are documenting thoroughly. You're getting everything in there to help the payer understand exactly what happened, where it happened, how long it happened. And then before it goes out, make sure you've got some sort of claim scrubber either built into your system like we do, or on the back end of your EMR, your practice management system. So before it goes out, you've got multiple layers built in there, so you send the cleanest claim every time.
Kind of from that, it sounds like data collection, that's more of a front like desk kind of responsibility. Would you say that's where most of the issues come up is in the front desk, or is there another part of that workflow where some of those things come up?
Yeah, so we primarily see two issues. One is always on the front end. So again, data collection, data entry. If there's issues there, or you're kind of speeding through, or even if your patients are giving you wrong data, which is hard sometimes to understand, to see. That's always an issue because again, the payers are looking for everything to be perfect, which is very, very hard, right? So you got a fast-paced environment. Maybe you've got a big treatment room. You might hear the wrong data, key in the wrong thing. It's just again having those layers and those checks in place to make sure what you did here is correct. Then on the back end is modifiers. We see lots of issues of modifiers. If it's a speech claim, depending on the payer, can have different modifiers depending on the state. Lots of issues there, making sure you get your modifiers right based on the type of therapy that was rendered.
Perfect. Okay. Another question. When a practice owner reviews an insurance contract, what fine print or clauses should they be paying the most attention to?
First and foremost, pay attention to obviously what the fee schedule is documented there. Again, it goes back to are you getting paid what you're expected to be getting paid. Also, be looking for any retroactive clauses that they could bring up. So, maybe they can change the fee schedule any moment without notice to you. You want to always make sure and get ahead of that. Try to get that out of the contract if you can, so you have a stable understanding of what's going to happen in the next months, years. Also, look for things like various AI clauses. Payers are tending to be very liberal with what their AI can do, but they don't necessarily love it when you're using AI to scrub the data on your side. Even though those are your patients, that is your data, it is your right to do that. We are seeing some various Easter eggs in payer contracts that can come back to haunt you, that they can activate at any time, they can change at any time. And so just making sure you're understanding, what truly is in there and then what could happen so you can know what to look for and be on the proactive side of it.
And kind of a deeper question, what is AI scrubbing? Like, how would you even on the back end describe that for me? Like, because I don't even fully understand it.
Yeah. So again, depending on the size of practice, the sophistication level is going to vary, right? Because a lot of this technology costs a lot of money and investment. So if you think about the payers, they're using AI to adjudicate a claim. Well, that AI is trained by humans and various other models. So, who knows if it's going to match up with the way your practice operates. For example, if you're a core facility, if you're an accredited facility with Medicare in that way, the AI does not largely is not going to be trained on that type of billing scenario. So those types of facilities, especially if they have some sort of accreditation like that, good chance the payers are not keeping up with you and what you have to deal with to stay certified or accredited. So it's always interesting to see kind of what they're doing. From on the provider side, if you do have the investment dollars, let's just say you've got an AI scribe tool or something that helps prompt you what codes to use, makes suggestions, helps you with your documentation. Sometimes they don't love some of those tools. I mean, they're very prevalent in the industry. I wouldn't say don't use them. I would say continue to use those for sure. But sometimes, the insurance companies get very particular about what AI tools you're using primarily after the fact, to look at different things. Maybe using AI to write an appeal letter. There may be issues there, but the big thing is that I've seen is they they're not a huge fan of you training an AI model on the data that they believe is there, if really that data is yours as a practice owner.
Gotcha. Okay. Thank you. Let's see. Next one. How many owners only track patients per day or total visits? What RCM metrics should they really be monitoring to know if their clinic is financially healthy?
That's a good question, Kylie. I will really say two things. One, your initial denial rate. So making sure that your best in class is going to be somewhere between 5% or less. And when I say initial denial rate, calculations are always super important in these metrics. So let's say when you're at initial denial rate, you're looking at your primary claims. You can go a little deeper. You can look at secondary and tertiary, but I'd say on that first pass, how many claims you're getting denied. So again, we typically see somewhere in that 8% range. Best in class would be 5%. So initial denial rate's one. The second one would be either days in AR or the concentration of your AR. We'd like to see at least 80% or more of your AR concentrated somewhere between 0 and 90 days. That's considered healthy AR. And so once it flips over to 91 days or older, then we start to get concerned about collectability. Now you're spending more time, more money trying to collect those dollars, which means you're eroding of the dollars you're going to collect. Those are really kind of the two North Stars, I would say. Other ones that I do love that will drive revenue, obviously, is your schedule utilization. So if you've got a schedule that accommodates 100 patients, how many of those patients are you actually putting on the schedule? So if you've done, look at the end of the week, you had 100 openings, you saw 90. That's a 90% schedule utilization. There's different terms for it. We do like to see that owners that really want to make sure their schedule stays full. So making sure that you're doing the same. Obviously some people look at cancellation rate, no show. You could do that, but I love the schedule utilization because that tells you if a slot opens up because of a cancellation, how quickly can you pivot and fill it with someone else who might want to come to the practice. So making sure you're doing that. Then obviously the therapy utilization is a big one too. If your therapist can see 20 people, you want to be tracking how many are they actually seeing, making sure that they're full. That also helps you understand if you've got a waiting list, what your backlog might be in terms of patients, because the more patients you see, obviously, the more revenue you can generate.
I know there's a lot of variety in the physical therapy space specifically, where you might have clinic owners that are 50, 60. They might be 25 and new out of DPT school. So maybe, like, let's say we have a clinic that's on paper, maybe a just slightly more experienced, seasoned PT. How do they go about actually figuring out these numbers? How do you recommend? Are they using Excel sheets? Like, where do they start if they don't have a robust reporting system?
Yeah, it's a great question. If they're on paper, obviously you got risk everywhere. So I'd say, you're gonna have to find a way to get that data into some system to build that out. I mean, if they're billing paper claims, we have a whole different complication there. But if the data is somewhere in a billing system or a practice management system, it's going through a clearinghouse somewhere. You would suspect. I would start there. If you're truly at a very primitive level, as you kind of described, I would say first go to the clearinghouse. What data can you get out of your clearinghouse, assuming you have one, right? And everything's not paper. There's always great information in there because that is the communication hub between what's happening in your practice and what the payers are saying. So clearinghouses are always great to see things, rejections, denials, things like that. Start there, see if you can get an export of that data, and really just kind of starting very simply. Look at your denials, what's coming in, do you see trends, what's happening? Because once you understand what's causing your denials, now you can go upstream and start to fix those. Is it something in your front office? Maybe you're not getting insurance cards all the time. Maybe we're misspelling things, not getting guarantor, things like that on, especially from a pediatric practice. So it tells you where to go to fix things if you could just get a simple list of your denials.
So when we, as even Strata PT people, are writing in their notes, those bills and claims are going to a clearinghouse and then to the payers and then back. Is that the right process? Correct?
That's right. Yeah, the clearinghouses are used to understand where that claim goes and to who. So, for example, even some payers use a clearinghouse to accept claims. So, kind of your typical names you hear in the industry be your claim goes to a Waystar. Obviously, Change Healthcare is a big one that's known for lots of reasons. It's going to go there. They're going to ship it off, kind of like an airport. They're going to send it to wherever it needs to go, Blue Cross, United, wherever, and then that that whatever the adjudication process, whatever happens in there, it's going to, that information is going to get sent back to the clearinghouse, and the clearinghouse will obviously ship it back to you in some form or fashion, electronically or paper. And so that clearinghouse is always good because that's kind of that's kind of the unbiased middle person that has the data that at least gives you a clue of kind of what's going on.
Gotcha. That makes more sense. Let's go to the next question. So, how should an owner evaluate whether their EMR and billing setup is truly integrated, or are they just leaving money on the table?
Well, I guess I'd put that question back in terms of integration. How would you define that? Are you defining that as the clinical encounters or in the EMR, the billing system is separate? Help me understand what you mean by integration.
Ooh, that's a good point. Let's just say, what if, let's just focus on the billing. What if their billing system, whether that's all in one practice or separate, are they communicating with each other properly and then even to the clearinghouses properly? What questions should owners be asking so they know that it's properly talking to each other?
Yeah, that's a great question. I mean, really depending on, if your EMR is, let's say you have an EMR and you have a completely separate billing group using some billing platform, the big questions you can ask there to kind of sanity check what's going on is obviously, look at your patient count. If you've got 100 patients on your list, obviously work with your billing partner, look at your billing system. Is there 100 patients in there? And do some quick reconciliation. Then you can obviously layer down from there. If looking at, again, are there denials occurring? If so, why are they occurring? And you can start to understand, is there data connectivity issues in that integration? Or is there latency of some way? Right. So if a therapist completes their note today, is it crossing over overnight, or is it crossing over instantly? Is it taking days? What's happening? You just want to make sure that flow is bi-directional, going all the ways you would expect. And so there's a couple things you can do there, obviously, to make sure that that's happening.
Gotcha. What are some of those things you were thinking about that you could do?
Well, like I mentioned, that just doing a quick patient list reconciliation. Again, if you got 100 coming in, do you have 100 going out? Making sure that you're looking at your numbers at a high level. That'll typically tell you kind of where to go. If something's not happening, then I would say you may have maybe you have a clinician documentation issue. Maybe someone's not finishing their notes. Maybe they're holding them and they're waiting a week. They're waiting 2 weeks. If they're on vacation, so you just want to make sure that there's a consistent flow on the front end of that. Your front desk is getting everybody from it through the intake process. Your clinicians are completing the visits, documenting the visits, and closing those notes, and they're not camping out on a bunch of different visits to close this out. And then once you kind of know that's a solid in a solid state, in a very optimized state, you can then start looking at the billing practices to see how many claims are going out, how many should be going out. Are there things getting caught in the rejection part of the clearinghouse because of whatever reason? And so it starts to kind of then pull all the fabric together to see like where you might have issues.
All right, next one. If you were advising an owner who's interviewing a billing company or EMR, what specific questions would you tell them to ask? Avoid being in the best position. So, what would you advise owners to ask their demos, basically?
That's a great question. Well, I'll start by saying you got to ask yourself a lot of things. Some of the trends we're hearing now is they want AI. AI can be very nascent. So, like, what does that mean? So, I would say, hey, before you go into these demos, which are pretty easy to set up, right? Strata is very easy to get a demo with. But I would say before I go and I light up demos and I start using my precious time, what is it I'm actually looking for that I actually need? So if you're going into a meeting or demo looking for AI, like what are you trying to solve, right? We talked about it before. If you're like, I need ambient AI, well, is your treatment room massive and it's going to hear 15 voices at one time? That might be the wrong thing to be looking for in the demo. If it is, you've got a billing person who's going to retire, and like, I don't know that I want to hire somebody and keep owning this. So maybe you're looking for a great rev cycle partner. That would, obviously that'd be something you'd want to ask during the demo, especially ask us because that is our bread and butter. So really ask yourself, like, what is it I'm trying to solve for? Is it more throughput, adding more therapists without incurring a lot of cost? Is it I got to solve my rev cycle problem? It's in house now, but maybe I want to find a partner for that. So I said, make sure you know what you're coming to the demo with to solve, so that'll help you ask better questions.
With reimbursements continuing to tighten, what tactical steps can owners take today to protect their margins?
Well, I mean, at a macro level, a lot of it's out of our control, but clearly some of the cuts from a CMS Medicare standpoint don't make anything any easier. We've seen those cuts just steadily continue to happen over the last 5+ years. So just know those are going to happen. So obviously that just means you got to make sure that you're constantly optimizing every step of the way, so that again, a clean claim goes out, you get clean revenue back, because what comes back is going to continue to shrink, from a CMS standpoint, government standpoint. Um, if you're Another thing is that depending on what you're adding into your practice, if you're adding more therapists or you're adding bolt-ons to your EMR, all that adds up. So just understand the economics of what's happening. So, for example, if you truly are looking to fill your schedule all the time, well, then what I would say is make sure you've got someone on your front, your intake process that knows if someone cancels, who are the 3 or 4 people I can immediately send a text to or make a phone call to get them on the schedule. Because again, keeping a full practice always helps with your margins, and just make sure any technology or ancillary applications or different things that your therapist might be asking for, that's all an expense. I would just make sure you understand what's the value of that expense, right? So if you're going to go and spend a lot of money on AI tools or whatever, just make sure that they're being utilized. Make sure that you're able to increase your throughput, see more people, right? It's all about how do you pay for all the things that you're bringing into your practice, and really make sure your margins are healthy.
Well, my last question, this is just kind of like a fun question, but why is it even called a clean claim rate? Is it clean because there is no denial, or can you explain that for me?
That's a great question. Well, internally at Strata, we call it the golden claim. The golden claim means everything happens perfectly throughout the continuum of rev cycle. So at intake, we got all the right data. During the encounter, we documented all the right things that happened during the therapy session. It went through the clearinghouse, it went to the payer. The payer said, great job, paying you everything you expected. Money came in, it got auto posted, and a human never had to deal with that reimbursement coming back. That's the golden claim. It's frictionless. We don't think about it. We do our job the right way every time, and we get paid the right way every time. The golden claim, or making sure you've got your first pass rate very high, meaning you don't have to worry about it. Because what I tell practice owners is every time you have to touch a claim, you're eroding at the dollar that you're owed, because it's your time, it's somebody else's time, it's technology to deal with it. So you don't want to have to worry about it. If it goes out and comes back frictionless, that's exactly what you want.
Well, Casey, thanks for jumping on. I know we'll be doing this more in the future, diving more into the processes of RCM and how owners can be more profitable. But thanks for coming on.
Thanks for having me, Kylie.
Hey, bye, Casey.
Take care.
Thanks for listening to another episode of Strata Stories. Strata PT combines your EMR and billing into one automated system to increase revenue and achieve a 99.99% reimbursement rate for physical, occupational, and speech therapy clinics. If you'd like to learn more about Strata PT and see how our EMR and billing services work, head over to stratapt.com to book a demo.